Good morning, everyone. We welcome you all to yet another webinar series, the weekly Sunday webinar series organized by the Society for Health Research and Innovation. The topic for today is point of care testing in acute clinical setting. Before moving on to the lecture, let me walk you through again some of the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. for you all to join in. No late attendees will be entertained thereafter, and each attendee should have been attended till the end of the webinar to obtain the certificate for the CPD points, and these CPD points are strictly adhered to the NCCPD guidelines. We do this to improve and maintain the standards of the CPD programs conducted by the SHRI. We thank you for your strict adherence to these rules and regulations. There will be a question time at the end of the webinar. If you have questions, you can type it in the chat box so that we can ask this question at the end of the lecture. If you have any specific questions about this lecture or anything else, you can email us to office13@gmail.com. Moving on to today's topic, it is a very timely topic. We will be talking about point of care testing in acute clinical setting. The speaker for today is Dr. Inuka Wijegunawardana. He is a consultant emergency physician at the National Hospital of Sri Lanka. He is the president of Sri Lanka College of Emergency Physicians. Over to you, sir.
Thank you, Dr. Dari, and good morning, all of you. Today, we are going to discuss about the point of care testing in acute clinical setting, and this topic is increasingly this is important because it is increasingly popular among the medical practice as well as it's using mainly the primary care as well as tertiary care. It is widely used all clinical setting in other country, but it now is in Sri Lanka. It's also now in emergency department and some primary care settings. It's becoming increasingly popular. And in this lectures, our objective, what is the definition of point of care testing we're going to, and impact of point of care testing in acute, in emergency setup and mainly acute setting, and what the current application of point of care testing in emergency care, and what limitation and challenges, and for further direction of the acute for the point of care testing. The definition of point of care testing is according to medical diagnostic tests at near or the bedside of the patient or the patient care. And according to the College of American Pathologists, it's a diagnostic test designed to be used at or near the site where the patient is located, and that do not require permanent dedicated space, and that are performed outside the physical facility of the clinical laboratory. Actually, this is apart from that, because this definition is given by a pathologist, it's the biochemistry and hematological test. But now we are adding some other point as well, because it's the ultrasonography and the imaging, and also come under the definition. It's not only the biochemical test, and it's need to include the imaging and ultrasound study as well. And therefore, we need to include that part as well. And this is it's actually diagnostic to include not only the biochemical and ultrasound both. And it should be in the bedside and it's near in the patient location. No need the bedside phases, and that perform is the outside the clinical laboratory. That's the important. Why point of care testing? And we in considering the clinical setup, one is patient admit to the hospital. One we assess the clinical assessment. What we at the moment we are doing is what the conventional test. We after making a clinical assessment, we come to some differential diagnosis and try to start the treatment. And that point, the testing is come into play. What these tests, how to do in that? We have to sample collection and need to transport and hand over and enter in the data and sample processing and test performance, and then test analysis and approval and collection of the report. That is called our conventional testing process. And after that, we get our modify our management and whether it's going to discharge or patient is going to admit in depend on those. This is one. If you go this conventional arm, and it take a time and it increase the patient number of accumulation in acute care setting and especially in the hospital admission, and it will bit of delay in the life-saving critical diagnosis because we are all depend on the what the test is sometimes, and therefore it makes some delay in diagnosis. And so what this point of care testing, and it's not, it's happen in the bedside and will save the patient time, and as well as the same outcome with the modified management either with the admission or discharge. And in this arm is more faster and it's more clinical, in clinical context it is safer and the patient satisfaction is more. And we'll discuss in further what are the other outcome and the problem and like. Why point of care testing? Why it is fast and focused? This why fast? It's usually in whole blood. We are not going to separate the serum sample, and we are not separating the whole blood. This is a this centrifuge blood, like separate sample, no need. Usually, most of all the tests more depend on the whole blood sample. We need a small blood volume. Usually, you know, it is conventional blood sample, we get 5 to 10 ml, but in here, and usually between the 0.5 ml to 3 ml blood sample is in. And simple technique, and it is inside the department, and no need a special technician for that. And results available usually within a minute up to 10-15 minutes sometimes. The result is available. And but we need to keep in mind something important, even at the end of lecture. This always the clinical assessment should come before any point of care testing. You should not use the point of care testing as your clinical assessment. Your clinical assessment need to perform first and make some clinical judgment and use your point of care testing after that. The clinical findings sometimes often inadequate when you see that when these tests are using in clinical testing. What we can see, what are the examples? The rapid triage, for example, we can go for troponin, bedside, and lactate. Those are the like clinical within first hour immediately can assess those tests. And also the point of care testing was used for some early intervention. We need to decide on NIV on arterial blood gas finding. Sometimes this hyper potassium and some electrolyte high sodium abnormalities, and we can measure from the bedside test, and then move on the early intervention, what we need. Point of care testing is a rapid decision making and quick initiate target management rather non-specific. This is we are going to do the target the treatment and improve outcome and reduce mortality and morbidity rate is shown, and reduce emergency department congestion and faster turnout time leading to quicker patient disposition. Because you know, as in the high dense population country as in Sri Lanka, when the for the acute setting and when the hospital admission come, and lot of patient in the admission side. And if you wait for the some results to get the patient decision whether it's admission or discharge, and it will get more congestion in admission side. Therefore, the point of care testing is helpful in this setup to make a quick judgment and get the patient disposition whether it's admission or whether it's going to discharge, and move on the patient turnover. Turnover time is become more faster when using the point of care testing. And it is increase the physician and the patient satisfaction both. and it decrease the liability risk because if you are coming with the test and if it was more accuracy and this is the liability risk is getting down and minimize the burden of at the central level. What we when we use our test as a disguise test, point of care test, and when patient turnover is high and reduce the admission number and centralize central level is reduced. And it is more space to the central level to get more specific tests. That is time consuming and so, and you can use that time for the more specific tests for page complicated patient management and more critical, unwell, or more non-specific patient management at central level. What are the application of point of test in the accident and emergency? This apply for the not only the accident and emergency department, even you can apply this for the primary care setting like OPD as well. Sometimes we can use the primary care primary unit even without accident and emergency department. This is still helpful. And sometimes even the ward is a casualty ward also that's more important. And but basically now we are moving with the A&E system and emergency system in the Sri Lanka, and we think in that way. What are the application of the point of care testing and accident and emergency? And we use mainly for some cardiovascular disease. Example, point of care troponin, and it's using for detect rule out or rule in test to diagnose myocardial infarction. And we'll discuss in later topic in this topic a bit of widely. And then the respiratory emergencies. We use arterial blood gas sampling as a bedside to detect hypoxia and also hypercapnia. This is type 1 failure and type 2 failure, make a decision whether we need to go ahead with non-invasive ventilation or whether make a diagnosis of pulmonary embolism. Sometimes it's helpful and make a clinical judgment to escalate to treatment. And the trauma setting and the especially the critical bleeding, and the fast test point of care as which is very important. Focus ultrasonography assessment of sonography in trauma to see the free fluid in abdomen and get it more advantage as a point of care testing in the trauma. And also base access in context of the bleeding, and what we are grading now the base access is sometimes this is an important tool to make a diagnosis of what the shock class is. It depends on the newest guideline. And also lactate for the bleeding patient, and this again the good bedside test to use to make a clinical judgment. And hemoglobin and not a year, that is also you can use as, but more the clinical sense is should come first because it, the dropping hemoglobin or it will take a time, and some people are still widely focusing about the hemoglobin rather than the clinical condition. I think so. That is those things which we need to be carefully used. That application sometimes we can that type can go wrong if used without clinical sense. Next one is the infection and sepsis. Mainly, what kind of infection and the septic bundle lactate is the number. Actually, first bundle is using as lactate guided by the lactate. It is a bedside venous blood gas. We include in the venous blood gas. And in the dengue, it is widely using ultrasound, point of care ultrasound to see the pericholecystic fluid and free fluid in the Morrison pouch. And if you are using as a dengue, it's to detect dengue hemorrhagic fever and there's a leaking phase. It's widely used in Sri Lanka, and actually it is some kind of a turning point to dengue management. It is reduce the morbidity and mobility of the dengue in Sri Lanka. Once the point of care ultrasound you start using point of ultrasound in like 2015 and 16 beyond, and we are using widely. And but it's again the you should not adhere almost always only for the point of care ultrasound and make I said altogether it is a collective clinical decision that means that the dengue fever uses the point of care ultrasound. And then what is next is the renal and urology point per se, and you know what the CKD patient and acute renal impairment. We use the venous blood gas to see the metabolic derangement, acidosis, and how bad is this, and what is the level of sodium, what potassium derangement mainly. We will discuss in with later week what this use of sodium and potassium actually is some leading to error or not. And also not much using the Sri Lanka, but it's a simple, it's a urine dipstick test as a bedside and to detect the UTI. And it is very cost effective and it's a sample and mainly we are using for the nitrite to see the positivity of the nitrite is mainly it's producing by the bacteria and it is very well established and have much sensitive test to detect urine dipstick with other with the cells and the protein and the nitrite and will make a diagnosis of the urine diagnosis of UTI in bedside. Is usually important and also in context of the renal calculi and renal stone disease, we can see hydronephrosis, hydroureter, and acute retention on those things using a point of care ultrasound and rapid make a rapid clinical judgment and make a decision was the initial management versus disposition and uh, to see the grading of this and severity of the problem. And endocrine and metabolic, and we are using most more from we are widely using for venous blood gas to detect diabetes decay, HHS, and sodium hyponatremia, those things in point of care testing. Also, for now, it's not widely used in Sri Lanka because it may be the cost. The bedside urine, sorry, the blood ketone level is also a very good measure to make a comprehensive diagnosis of decay. And or if you can use urine ketone level as urine dipstick, it usually come the ketone. And I think so. We need to encourage those tests in Sri Lanka. It is usually we are sent to the laboratory and wasting our clinical time to make a diagnosis. And but it can do in the bedside. It's widely using all over the world and still yet to the increase not much popular in Sri Lanka countries at the moment. And we need to encourage it in acute and primary care setting, detect those urine dipstick with the urine ketone bodies level and the especially in some is the physician consultant available in context blood ketone as a rapid diagnosis of this life-threatening emergency. And then toxicological things, and we can use toxicological kit for various to detect various drug substance in currently, but it's a bit of cost and not to use each and every case. It is specifically and with the your clinical sense because of thinking about the cost. And venous blood gas, we are again using to see some significant metabolic derangement, the acidosis, and with a significant poisoning level. Look, for example, you can use tricyclic and depression. Like this, the blood gas is more important. And obstetric and gynecology, and again, some point of care ultrasound is coming to play in the in emergency setting, and you can detect pre-fluid, and you can detect intrauterine pregnancy, and like this is not go to up to the gynecology and obstetrician level, and with the train, and you can detect those things and make a diagnosis ectopic pregnancy as a supportive ectopic and well as some kind of some in gynecology, ovarian solution, and those things also possible as a bit in bedside clinical judgment. Now, the next thing is the imaging and procedure guidance, is widely used in central line as a ultrasound as a bedside test to detect the get the guide the central venous line insertion. Uh, Also, not much popular, but still increasing popular is the peripheral cannulation. It's a difficult cannulation guided by the ultrasound, and I think so now it is becoming popular because it's a difficult cannulation in the peripheral cannula. We can insert using ultrasound by visualizing the ultrasound. And also, apart from that, we can give some nano block, those kind of, especially fascia like a block, femoral block, these things, and from using ultrasound, it can use widely in emergency setting, in the trauma setting. Okay, now you can know what are the, there are a wide variety of application of point of care ultrasound, point of care testing, the blood test, ultrasound, and so to make a number of in diagnostic conditions and a number of clinical condition we can use. That is now you can understand what how important it is in our acute clinical setting. Now we have moved on to the especially important free topic. It is a blood gas, troponin, and ultrasound, and which me to discuss a bit of thoroughly because it is widely using and some errors happen during this, and therefore we need to be discussion about this blood gas analysis. And this is blood gas analysis is increasingly popular among the bedside. What is the we are you get how to get this blood gas analysis and how to interpret this one and what are the errors can happen and things we need to see. And during active it's a blood gas we use syringe usually 1 cc to 3 cc syringe we are using. The amount of blood need for the blood gas is depend on the manufacturer's advice. This is it depend some it's vary between 0.2 to 3 ml. It widely most commonly 0.5 to 3 ml. But it you always need to refer your what the that blood gas machine manufacturer say and this amount please obtain around that amount and it usually whole blood between 0.2 to 3 ml is used. It depends on the manufacturer. But when if you take in this blood sample, sometime some errors can happen. What are those blood? If you widely get tight your tourniquet around this puncture site, it will give rise to some local hypoxia and hemolysis effect. It will give rise to error sampling reading. For example, if you widely tourniquet because it is difficult to get a blood sample, especially in the venous blood sample, and it will produce local hypoxia and if the lactate level may be high, where the patient is clinically, that's why the clinical judgment is important. Sometimes when you think the very high lactate in blood gas, you start in the treatment, but in the paper, the patient wise, patient is not such a no clinical derangement from patient side. And because of some technical errors happen when you start withdrawing the blood from the because of the type pressure, leaving local hypoxia. Also, the hemolysis will lead into erroneous hyperkalemia. It is a hyperkalemia treatment. You think is always need to guide it with some time because of you can get the ECG in case of it's a doubt. And what other the most common but you raise the heparinization of the sample. This heparinization of the sample usually because we don't have pre-filled heparin syringe in Sri Lanka because might be the cost is the reason, but finally we still not evaluate why this heparin effect actually the pre-filled heparin is much more is cost effective. Why? After analyzing the old thing, because we usually use 625 international units of heparin, sodium, and for get the heparinization and flush this syringe. But what will happen is usually if you not properly flush and this thing, the heparin will remain in the this syringe, especially in the needle, and it will give us to false results. Most of the results will get deranged with this presence of the heparin. For example, if this heparin is a significant acidity and it will directly affect the acid-base status of this blood sample. And other thing is it will affect the potassium level because it's a heparinized sample, it will give rise to hyperkalemia. This is the hyperkalemia because of not due to the ring, it is excess heparin or sometimes retained heparin. And heparin will bind the calcium. It is because of large molecule. If you want to measure the calcium level, it will always show hypocalcemia in the blood gas sample because of the heparin level. There are so many things happen with the heparin, and therefore we need to keep on eye at the proper heparinization of the sample and clearly flush it off before you insert into the blood gas analyzer. And just if other thing is you need to read what amount of heparin need for this blood gas machine. Some are getting some various reasons between 625, some days 1,000, and there's no exact value for the or like using the old machine. This is something it depends on the machine. Always prospective manufacturer reading what amount we need to heparinise this for sampling. The most important thing is we need to encourage to use pre-filled heparinized syringe, and it will reduce this burden with the detection of heparinization and over like amount of the heparin is vary and retain the heparin will reduce with this pre-filled syringe. It can fluctuate easily and the things can go. And that's what the second concern of the heparinization. And the next one, this is the interpretation of hypoxia and hypercapnia. Again, important because you need to make sure that the arterial blood gases is mainly for we are going to arterial oxygen saturation and arterial carbon dioxide saturation. But using carbon those mainly need arterial blood gas, not a venous blood gas. But in the most of the time, we are using the radial artery to get the arterial blood gas. You take from the closest vein, and might be the result might be wrong. That's the one thing. And other thing is we need to do in correct time period. If you're getting more and more, with maybe you if your blood gas machine is not nearby or it is more than 5 minutes or 10 minutes away, and you need to wait for the queue for the do the arterial sample, and it will give rise to false positive hypoxia, and this is hypercapnia as well. Therefore, need to interpret properly, and you need to liaise with the relevant unit with the blood gas machine because it is not like a central like a teaching hospital might be in the district general and base hospital. There's be only one blood gas machine available for the whole hospital. If you are using the point of care testing in the blood gas in this might be the end of the story of this whole hospital because therefore we need to get the thing proper way and adjust your local settings according to available facility. Therefore, hypocapnia is real clinical judgment and make it real necessary to assess this hypoxia and hypocapnia in clinical context. We need to justify first why you need this one. Because it's obvious patient is hypoxic in the pulse oximetry. why you go behind again arterial oxygen saturation, but in some circumstances need. But for example, methemoglobin, we need to detect the dissociation by the hypoxia and hypoxia, arterial oxygen, and the pulse oximeter reading. And other thing is, if you get air bubble in this needle, and it will absorb into the blood, it will give rise to false positive hypercapnia, because the air bubble contain is like the falsely positive carbon dioxide value, and therefore it likely high carbon dioxide, then we might give rise to high carbon dioxide value, and we need to be careful on that as well. And yeah, this is mainly then the interesting is to measure the hyposodium disorder with the blood gas analysis. Because of the lab value is significantly delay in patient is impact of the patient management, and most of the people will rely on what the blood gas sodium value. What are the actually by comparing the all electrolyte level measurement in the blood gas, the sodium might be the most accurate thing. The sodium is, but it needs to be careful. This is no error. Sometimes you take a blood from the same use sending the sodium chloride infusion at the same arm and taking the venous blood gas might be have sometime get error result. And but if it's not there, like giving the blood, withdrawing the blood sample, most of the it is standard blood gas machine give us the most accurate sodium value, and it's near, but it might be changed one or up to 5 millimole. They think we need to careful. And you always use the clinical picture with the sodium if you want to correct the hyponatremia. Until the first 1 or 2 hours, until waiting for the your proper sodium value from the central lab, you can make some clinical decision, and management depend on the blood gas sodium. For example, you say with our blood gas sodium came as 120, and patient is drowsy and vomiting, and that is something you can, the blood gas, so is hyponatremia, you can give 100 ml of hypertonic cell, and it will not give rise to rapid drastically rise in sodium value, because it give rise to unknown maximum 3 millimole, and it not affect, so it not going to risk of the patient go to central contained business with that. But if you can't use that judgment for long time, just for limited to the first 1 or 2 hours, and then get down your lab value and make a compare with that sodium and this sodium with, and then make a proper clinical pathway according to that. This sodium thing, that is important. Considering the potassium is, I think so, best advice, be careful because potassium always going wrong in the blood gas, because thing is the technical errors can happen. I say this heparin, or whether this sample is going to Himalaya. Sometimes the blood gas machine cartridge and this calibration issue will happen. Therefore, is the potassium is very cautiously used. Don't just first potassium. What we can do, what you can adhere to your clinical context. If someone is acute renal impairment and come with the hyperkalemia, that most likely may be true. If sometimes this is the clinical, then take a ECG and show that hyperacute T waves, and there is a various degree of heart block, LBB pattern, first degree, second degree, like that. Then you can judge, yes, that might be a correct, and you can make a life-saving clinical decision like administering calgluconate and giving insulin dextrose in that setup. One more example is patient on the potassium sparing diuretic like spironolactone, and they end up with the renal shutdown, and then make the hyperkalemia, and your blood gas so hyperkalemia, then you can justify that. Like that, the clinical justification first, and then you go to the potassium, might avoid such a gross error. Because sometimes you can see there's a significant 1 to 2 millimoles difference in the blood gas sampling potassium and the lab value. Always get the clinical judgment and some agents like ECG to avoid these errors, in blood gas. Uh, Regarding the chloride measurement, and usually blood gas machine require chloride. Some blood gas machine not give rise to chloride because then it is difficult to get the full interpretation like high anion gap metabolic, and I think so. Better to have chloride value in the blood gas. Again, the chloride value also not much clinical impact, but this error happen is with of not such like potassium. Therefore, we can use some clinical judgment. This is hypochloremic metabolic acidosis and some kind of metabolic alkalosis, chloride responsive or not. Those things by looking at the chloride. It is some clinical application can happen. And next one is the calcium value. Actually, the calcium value is the questionable thing. So, because hypocalcemia, we can't judge by the blood gas machine because again the how we collect the sample and the technical layers and tourniquet effect, lot of things. Therefore, the calcium value reliability is still not much sensitive or specific. Sensitive in this. There are significant number of false positive values can happen. And magnesium value in blood gas is promising and like still not widely used in Sri Lanka, still yet to come. Might and according to the literature happen in the UK and Australia, this is the standard. We can use measure magnesium ion value to detect hypomagnesemia because it's going hand to hand with hypokalemia. Hypokalemia, and you can get, but problem yet to decide what how clinical implication is important because sometimes we can clinical judgment can decide and we can give clinically a magnesium sulfate for the patient even while without looking at this magnesium level, but it is important to have get a proper clinical measurement, and in that case magnesium might be helpful, and we'll wait and because it's not widely used in Sri Lanka at the moment. And next one is in the blood gas, we move to the lactate. The lactate value, again, very important to detect sepsis and bleeding, tissue hypoxia, detection of it. Actually, the only thing is the blood gas analysis. There's no other way to make a lactate with the centralized lab will not widely using for that check the lactate value. But is lactate again, I say the local effect, those things can happen. Sometimes the convulsive patient can give rise to high lactate transiently because of the oxygen demand is high. And those things we need to judge with that before starting the treatment. And the hemoglobin using a blood gas analysis actually uh, somewhat helpful, but is no, otherwise is somewhat is a misuse, and it is somewhat in the trauma settings and the bleeding is concept is obvious with the patient is unstable and you are looking at this hemoglobin and make a decision is called misuse of this investigation, and therefore this type of they can measure the hemoglobin, but it's a kind of not routinely advised to check those kind of thing as a test of screening, and it will give rise to false positive or false negative value and mismanage the patient. Then what the interesting thing is the glucose. And what is important, more accurate blood glucose can measure with the blood gas. I think you know, I somehow might know the reason. The blood gas analysis actually measure called the D glucose. The D glucose is the most accurate measurement. While looking at this, your capillary blood gas, glucose level is not specific to the D glucose. It is not going to measure the D glucose only. We have the other false positive value can happen. Therefore, the finger prick blood gas have usually 10 to 20 milligram deciliter higher than the blood gas sometimes because of the some false positivity can happen. But it's the most accurately you can see the glucose level in the blood gas. It is called D glucose. Thing therefore be careful once you get a hypoglycemia because definitely if the blood gas analyze show high low for sugar, it is hypoglycemia. But sometime it will say this more, our blood sugar cutoff for the hypoglycemia is 70 milligram per deciliter. And if your capillary sugar show patient having 80 milligram and the blood gas show is 60 milligram. What is correct? This blood gas is the correct because it's theoretically and technically. And the blood gas, but your thing is mainly go for the clinical judgment. If someone is unresponsive and some neurological deficit can happen, is showing that the blood sugar level is, you are thinking about this patient have a possibility of hypoglycemia, treat hypoglycemia. That's the things you need to make a clinical judgment. And that's how the glucose used in the blood gas and is more accurate in the blood gas. But both the cost and the clinical concepts, you use 150 rupees for the capillary blood gas. You are using 1,500 rupees for the whole blood gas. Don't use blood gas ABG for the check the glucose. That is the one limitation and thing. And next test, so-called point of care troponin test. Point of care troponin test is now currently increasing use in our emergency department. Mainly where the specialist emergency physician is available. And because it's a point of care test, troponin test is important to make a clinical judgment, important to decide on whether patient is a high risk patient or low. The point of care troponin, and currently there's no point of test for high sensitive troponin in Sri Lanka. But we have ultra sensitive and things are view. But it's promising to come the high sensitive troponin. We can use high sensitive troponin to make a clinical judgment. Specifically, if the patient is a low risk patient, you can use the troponin test to make a discharge plan and make outpatient clinical management pathway for the chest pain. That's the why that is important as a high sensitive, but some clinical concern is don't make a troponin to decide to your clinical decision. Because, for example, if the patient is having chest pain and it's suggestive chest pain with a context with the high risk and everything together is unstable angina, still your troponin is negative. With that, you should decide if the troponin is negative and this patient is safe to discharge and everything is that may give rise to wrong clinical implication because might be like considering the acute coronary syndrome with the 20 to 30% of people have end up with the unstable angina category. And this is a non-STEMI, another 30%, and this might be the STEMI is only just for 5%, 5 to 10%. What is the acute coronary? If you discharge this depend on the troponin test, might not give rise to good clinical decision if you are if not careful interpret your clinical assessment. That is the thing. So they are based on this is called multifactorial, multifactorial and multidisciplinary approach, and clinical this troponin used as a supportive test and with the clinical thing, and do not use troponin as a like a test to lead to your clinically. Is that just but we need to get now it's the troponin to discharge this time 0 and time 1 hour or time 0 and time 2 hour. There are several quantity for the high sensitive troponin. We are discussing about the point of care for the discharge pathways in the high sensitive troponin test. But if you chest pain is more than 4 hours or 6 hours, still bedside troponin, apart from the high sensitivity troponin, we can use that because this is clear cut thing and it's a clinical judgment. We can go for the safety network and avoid the unnecessary admission because most of the hospital admission go for the chest pain. This is but if you have some safety network can create with the point of care troponin test, if the chest pain is adequately analyzed and the time onset is adequately analyzed and then the risk factors and the ECG, everything together, we make a clinical judgment whether the patient can discharge or not. And the point of care troponin is came as it's like a test kit sometime, and be careful. Some troponin test the value, the reference range is a bit of higher. It's like you are going to use point of care, the high sensitivity point 0.005, and then is come with the point 0.01 as normal troponin, conventional troponin. Don't much give burn to that conventional troponin. Always ask your manufacturer, literature, search and think what is the troponin, what is the sensitivity, what is the specificity, what is positive predictive value and those negative predictive value, and use that according to the specific test in your department and make a decision. It's always get go with like patient with central individualized care compared to the global thing, and individually you need to see the patient. And it is about this point of care troponin. It need a small blood volume, actually is 1 to 2 ml. And this cost wise per se, the point of care troponin test and the high sensitivity troponin is the central lab must not give rise to much not give rise to big amount regarding the cost. Cost is might be the same. What is the conventional troponin cost is bit of low compared to the high sensitivity troponin in the central lab. Then very important topic, point of care ultrasound is called focus. Widely using as a bedside test now. What are the mainly used tests is called fast focus ultrasonography, assessment of ultrasonography of trauma, and the lung ultrasound is widely using in clinical test, detect the pneumothorax, detect the pleural effusion, and even detect the pneumonia. And the cardiac ultrasound used is detect the pericardial effusion, tamponade, just eyeball contractility, how it thinks, and this the more training is there, then you can see some wall motion abnormalities, but need specific treatment. And procedure, as I said earlier, the CV line insertion, central venous line, and can give us nerve block, and also difficult cannulation. For the peripheral cannulation, we can use the peripheral ultrasound to avoid to insert central line. And yes, what bit of wording about this point of care. The point of care ultrasound, before using, we need to concern about the machine and the operator and the clinical judgment. The machine, it should be portable, and it is need kind of very convenience to the interpreter. This is the physician. This is not like a very large machine happen in the radiology department. It's usually what we use very conventional machine. It is compared to the cost is most almost one third of the cost in the standard machine. Now it's promising that we are getting more handheld ultrasound machine using your laptop or phone and Apple devices, and you can use that even. But it is cost per se, it is very less cost. But the technical advantages and image quality and everything we need to justify thing to get. But the more important thing is we are not go for higher diagnosis, and we will say some very gross finding to make a clinical judgment. That per se is in case with this image quality we can up to standard in that level, not for the such a higher degree of to detect some vegetation like thing. There is a thing. So it's very high gross findings we detect in the ultrasound. And other thing is comparing the matching the cost and the standardization image quality. And next one is operator. I think you should follow proper training to get the point of care ultrasound and need accreditation for that. I think so. Otherwise, if you use the point of care ultrasound like things like even you like ECG, you need specific training for that. This because the point of care ultrasound usually no training happen in the medical school or the intern. It is the training happening usually after that. Therefore, please follow if you are interested to use the ultrasound as a bed test, you need to get proper training. In the other country, you should accredit for the ultrasound. Otherwise, you can't make a diagnosis using ultrasound. Because otherwise, then what happened is it's going to do for a lot of errors and very non-specific diagnostic thing can happen, and even it's mislead, it overuse, so it is misused by the operator. Therefore, operator should be very adequately trained for this. And other thing is this the machine is should be maintained properly and think because if you use the point of care test, this machine is widely using and is moving here and there, and so this is the maintenance and the machine calibration and those things, and then they should be updated at least in periodically. Otherwise, what is the quality is going down and machine half life is this is a machine technically is going down think because used not widely, not used proper way and not serviced in proper time. Uh, that's how we use these things. And for example, the past is usually mainly in the trauma setting, and we need to see the pre-fluid in the abdomen and the pericardial effusion. And for the lung ultrasound, we can detect with it is detect the pneumothorax and pleural effusion, and it is using very widely because we can see how difficult to get the chest X-ray into the department. Is your bedside patient to detect the pneumothorax. Not, I am not discussing about the tension pneumothorax. This is the discuss spontaneous pneumothorax. This will miss, but is using the ultrasound. Nowadays, we can spontaneous or secondary pneumothorax detection might be very easy. It is around nearly 98 to 96% sensitive, and it is around 97% specific to detect the pneumothorax in using the lung ultrasound with the experience and trained operator. They are very important, these things. And first the cardiac mainly in cardiac arrest situation and also in the hemodynamic compromise, we mainly use the ultrasound to detect the pericardial fluid. Either it's go to the tamponade or still significant amount of the pericardial fluid around the heart. And also detect the pulmonary embolism. If the patient are somewhat patient hypotensive and the risk factor is suggestive, and you can go for this RV dilatation and see whether it's a lung, this RV collapse is there, and but need bit of training for that. And to detect massive pulmonary embolism bedside is using the cardiac ultrasound. Another thing is you can detect the contractility of the heart. The contractility actually this was a you can get need to more training and get the eyeball contractility, or you can measure proper way. Like you can there are various measurements like the EPAS and these things. So ejection fraction measurement even as a point of care test. Uh, from eyeball to like with a wide, it is a wide variety of that range we can use for this cardiac ultrasound. And but in the cardiac ultrasound, the image get most important thing is how to get the proper image. This thing there right is or not always subsequent approach, and there are there are various approaches. There is called low parasternal short, long axis, short axis, apical. All view need to be familiarized. Get the proper image. And next one is the cardiac case is called IVC, IVC variation and the diameter. And it is well validated to intubated patient IVC because at the intubated patient there's a positive pressure and we breathe in a negative pressure. And there are no such a gross evidence or literature say it's the IVC measurement in widely using in the spontaneously breathing patient. So we can use as a surrogate marker and make a clinical judgment combined with the other decision. Don't alone you can use the IVC as the hallmark of the hypovolemic stage of patient in shock. Just get the other parameters and see. This, for example, you can combine the cardiac and together and make a proper clinical judgment. Next one is the procedure. It's a CV line. I think so. It is usually using more than 10-15 years in Sri Lanka now. Widely using the central venous line, but nerve block. I think so. Need to encourage, especially fascia iliaca block, because elderly fall and uh, neck of femur fractures is increasingly common, and there is a geriatric population. Is during the hospital admission, it will reduce the morbidity, and the patient satisfaction outcome if using the nerve block and early mobility until the fixation happens. This for the fascial iliaca block, and the so is important. Also, you can use to nerve block for the procedures like you can think like reduction technique and so, and but need a bit of training in the practice management. I think the interesting is the peripheral cannulation. Actually, they reduce the number of CV line and pair cannulation. Once the you start point of care ultrasound as to detect the peripheral vein and insert use the technique to insert the cannula using the ultrasound. It is reduce the number. And the important thing is in our Sri Lankan setup, our cannula is not designed for the peripheral cannulation. And usually you need to use 20 gauge or about 20, 18, 14 like that. And another thing is you can't go beyond 2 centimeters depth. Precisely because after 2 centimeters you can't judge much because it is not designed for the cannulation, peripheral cannula. In the other country we have special design cannula for that. And but in still using our cannula we can use, but use wide bore cannula and take a depth with up to the 2 centimeters. Most of the time we can have cannula vein at that level. Because the anticubital fossa you can use this in where at the level of 2 centimeter, you can find a cannula vein and insert a cannula. And you master this technique, it will actually say, improve the patient outcome and the, your satisfaction as so you can insert this. That's the use of point of care thing, ultrasound, in our clinical context. And then let's move to the some limitation and challenges. Actually, we are discussed during this lecture already. And it is what the sensitivity and specificity. It not. It depend on the test. It depend on the what the manufacturers and so. And it is therefore you need to think about what sensitivity and specificity before using this test. And accuracy and the reliability, and it is used as the pre or post test analytical errors can happen. Therefore, the reliability uh, judgment and operator variability. Results will depend on the user skill and adhere to the protocol at this company. Training of operator. As you see, the ultrasound, it need a training. Storage of cartridge and expiration. For example, you need to widely use this cartridge usually expired within 3 weeks. Blood gas cartridge usually expire only for the short period, not like a long half life. The cartridge need to expire, and the storage might be a problem in primary care setting and the emergency department without significant facility. The higher per cost test, per cost test again, but it should be justified properly because if you say the cost of the centralized lab test and this cost only need operator, not no need a skill operator for the testing for sample. And centralized lab, you need to send the sample and need to process the sample and you need to analyze, and need to be a separate MLT should be there. Therefore, considering all stages, might be the central cost might be a bit of higher than this cost. But per se, the test cost might be the higher in here. But in the long run, no, considering the all clinical judgment, the pre-test cost might still in advantage and value and low in this point of care. But if this should come before any point of care test. That is the number one clinical thing, and we need to do. Point of care test should be used wisely in the clinical judgment to ensure the most accurate diagnosis and treatment plan, ultimately improving the patient outcome and reduce morbidity and mortality. And this is like not a like a AI. It is not like a AI like thing. You replace your clinical knowledge with point of care test. It is kind of a supportive test for the improve the patient outflow and increase the turnover. Therefore, make that your clinical sense still first. Inviting the explore area to implement and use point of care test, and we need to introduce into Sri Lanka and get more yeah, explore the area how to use this and need do more research as things it's a still limitation of study in this area. I think so. This is the end of our lecture. If there any question, is I'm happy to answer. And thank you.
Thank you, sir. There are a few questions asked in the pre-assessment forms. Um, uh, the how to attend a patient presented following a drowning.
Sorry, I tell it again.
How to attend to a patient that is presented following a drowning.
Yeah, is that for use of a clinical this for point of care test?
Yes.
Okay, see, actually, it's a concern about drowning patient. Huh?
Yes, sir. Drowning patient.
Yeah, it is a drowning patient. In the point of care test, I think so. It's a limitation because it's a drowning per se. The electrolyte imbalance, everything is deranged. This is, for example, you can, the hypoxemia not depend on the clinical test. You can use blood gas to see the hypoxic level, but it not change the clinical management mind. If the patient is drowning and patient is severe respiratory distress, or is in the arrest and get that, it might be still the same management. And the sodium level, potassium, everything is deranged. And because seawater drowning on water is it's like mineral water, it depends. Therefore, better to kind of the limitation of use of point of care test in the drowning and make more towards the clinical judgment. Proceed the thing, but still you can use arterial blood gas to see the improvement and things so. When better advice, no use the electrolyte imbalance things with the centralized lab in case of drowning.
There's another question. Can the point of care testing facility can be extended to a district hospital level in the primary care level? Because at DHS only CBS ECG is available. How can we incorporate this into that setting?
Yeah, actually, good question. It is not only district general, it can even incorporate to the ambulance. I think so. We are the moving away to this, including to the suicide ambulance service, this ultrasound, because handheld ultrasound you can do and we can interpret centrally by experienced clinician. For example, if you are is a district hospital, if you have ultrasound with the point of care, with some your training, if you get some training, and you can use this ultrasound, you can use telemedicine to deliver the image to the center, like a teaching hospital or the district general hospital. If it via the emergency physician or some the specialist is available, they will interpret and make a joint clinical judgment. I think so. We need to move in that stage because for the patient safety with the trauma and the cost is low in point of care ultrasound. It is just maybe around 3 to 4 million. It's normal conventional ultrasound. It's nearly 20 million. It's more than 6, 7 times lower cost and get widely clinical use and increase the patient. I think so survival. And so I think we need to through the we will go for the cluster gas type of system and expecting to introduce this point of care ultrasound to the district general and be even lower than this whole ambulance. I think so. This is our future target in Sri Lanka in probably the next 5 years. Using some at least the pilot study need to done, which you can use in the district level.
Thank you, sir. There's another question in the chat box to explain a little bit about the potassium effect by heparin.
Actually, the potassium, one thing is the all, this heparin, it is included, it bind to the whole molecule, it will reduce the potassium level. In other way, if the heparin is mainly affect the calcium, but it affect of the potassium acid. The potassium is acidic. Acid is a molecule and is usually the acidic environment is a cell. It is the acidosis will lead into hyperkalemia. This is a context with the surrounding solution is acidic. It is the sample show the potassium value is in high when interpretation. That's the thing. And apart from the heparin, other thing is like hemolysis and so. And chance of hemolysis is bit of higher with the heparin is bit of overloaded with the serine. And that's also other lead into error positive hyperkalemic result. That's the how the heparin will affect. This should be avoided by pre-filled heparin syringe and its facility to flush properly. It will reduce this issue.
So there's another question. Is it the deep veins that you are referring to regarding to ultrasound guided cannulation?
Sorry, is
Is it the deep veins that you are referring to with regard to
not,
ultrasound scan guided cannulations?
not a deep vein. So-called mainly we are using antecubital fossa. Is the antecubital vein and cephalic and basilic vein. And in the cubital fossa you can use with the ultrasound. Usually it should be the depth in between 2 centimeters because you can't go beyond the 2 centimeters and insert the deep vein like in the forearm. This is a forearm, some deep veins are there, but it is not success if the vein is more, depth is more than 2 centimeters. Therefore, the preferred site is the cubital fossa and just below the cubital fossa, we can use it. Usually, the vein should appear in between up to the 2 centimeters level. And usually the wrist at the radial vein and so we can visible. What is the usual preferred side is the cubital vein, cubital fossa, and go to the even the arm. We can use the basilic vein as well sometimes. This is in difficulty.
There's one more question, sir. What are the training programs available for focus training in Sri Lanka?
Training program currently conducted by College of our college, Sri Lanka College Emergency Physician. You can go to the college website and contact us regarding the training. I think so. The very huge queue and demand is there. Usually conducting every month. Apart from it is called the point of care ultrasound, all including trauma, lung, cardiac, and everything and the basic and advanced, and you can come for that. And some other colleges also conducting ultrasound, mainly the surgeons for the trauma, for the past scan like this. There are only for that limit for there. Yes, that might be. I know only that, but mainly we are conducting for our college point of care ultrasound course. Thank you. I think so. The end of the program and no question. Thank you, everyone.
We thank you, sir, to taking time out of your busy schedule to impart this knowledge on us. We thank you. We sincerely thank Dr. Inuka Wijegunawardana, consultant emergency physician, National Hospital of Sri Lanka, and the president of Sri Lanka College of Emergency Physicians for your excellent lecture and your precious time. Thank you, sir. There's a link in the chat box to fill the post-assessment form. Please kindly give your feedback through the assessment form. And you can receive your e-certificates of participation within this week. We kindly invite you to join us next week, next Sunday also for another session organized by the Society for Health Research and Innovation. Thank you for your participation. Have a good day.